Hello and welcome everyone. We are live on Oral Pathology 360 for a very special event, the Rising Star Grand Finale. It's great to have you all here and with us for what promises to be an exciting and inspiring showdown between what I would like to say equals. So they are both great, and we will just have to somehow bite the bullet and choose one, but both are great. In the meanwhile, let me welcome you and just remind you that we have our membership open for anyone who wants to join. There are a number of perks. And to thank our latest member, Dr. Alifa, then, to remind everyone that we have a great thing today, that is announcing the giveaway. One lucky attendee will win a free registration for the IODCPC 25. And that is as usual. Every year we have them coming up towards the conference. And this year also we will have in every live stream until the conference. So don't go anywhere. You need to stay right till the end to be able to take part. And then, of course, the conference itself. Let me tell you a little bit about the conference. It is the International Oral Diseases Case Presentation Conference. This is the fourth one. So, this is the 2025, and it's the fourth one. The main conference is between May 2nd to 4th. It is fully virtual. The pre conference is on the 26th of April. There is a 15 days replay for both the pre conference and the conference. And of course, one pre conference is free with every registration. It is for dentists, doctors, specialists, really anybody who has an interest in the oral and maxillofacial region, whether you are diagnostics or managing patients. Of course, and what else can I tell you about it? Yes, the first 100 registrations are at a very good discount, and it is on. The abstract submissions are open. These are the wonderful keynote speakers that we have. I think you might recognize everyone depending on which field you are in, but they're all really globally known in their own field. And this is the panel of great speakers that we have. And as you can see, there is the spot that is left for the rising star, which we will fill up today. And what next? Let's see. Oh, yes. So today we are coming to what we are going to be doing today, and we witness the final face off between two incredibly talented finalists, Dr. Shivani Mungala and Dr. Meghna V. Nayak. They have both proven their excellence by winning the open mic contest and also by presenting lectures here. You can see the thumbnail of each of those lectures. You can always go back and catch them up. Now, they will compete today for the prestigious Rising Star guest speaker opportunity. So, basically, the one who wins today will be the guest speaker there. It's a big deal, I think, and it's fun. It's really fun. Then, let me introduce our two judges. To ensure a fair and insightful evaluation, we are honored to have two esteemed judges, two great friends, also from the IOD 25 organizing team with us today. We have Dr. Karpiga Selvi Sanjay, convener of the guest lectures. She represents Vaidehi Institute of Dental Sciences from amongst our co-organizers, and Dr. Nandini DB, who is the convener of oral presentations from RIMS Imphal. They will be sharing their expert opinions and helping us decide who earns the Rising Star title. But we will also need your participation to make this event even more exciting. Cheer for your favorite finalists in the comments, share your thoughts, stay with us till the end, and there is going to be voting at the end. So just hang on and stay there. All right, get started. Let me bring everybody in, and instead of just talking to you myself, right, there you are. And welcome, everyone. It's wonderful to have you here, and welcome to our viewers also.
Thank you, Mandana.
Thank you, ma'am.
You're most
You,
welcome.
ma'am.
Welcome. Okay, should we go on to the first presentation and then come back later? We will chat.
Yes, we can do
Okay.
that.
Okay. Oh, and by the way, for everyone's benefit, quite coincidentally and without any pre planning, both have chosen the same topic. But we will see the flavor of the difference with each of them and how it works. Yeah. See you all back to the presentation.
Hello, good evening, everyone. Today we'll be discussing about the topic varicopapillary lesion, a roadmap from confusion to clarity. Today we'll be discussing about the terminologies, classification, identification points, diagnosis, and management. Coming to the terminologies, the first word that is varicosis. It is derived from a Latin word which means pertaining to, like a formation of worth or a worthy lesions. The next terminology is worth, a small hard benign growth caused by a virus. The next is papillary, that is pertaining to or resembling a nipple or a finger-like projections. When we say varicopapillary lesions, these are the group of the lesions that are diagnostically challenging as they include a wide spectrum of benign, potentially malignant, and frankly malignant lesions. Coming to the classification, in 2003, Rexis has classified these lesions by their types. In 1983, Eversole and Papadopoulos has classified the lesions according to their appearance. In 2000, Eversole again classified the lesions by the involvement of the human papillomavirus as an etiological factor. And in 2009, finally, Thomas and the Barrett has classified these lesions into benign, potentially malignant, and malignant lesions. Now, why there is a need to discuss about the varicopapillary lesions? The clinical image you can see in the slide, they have a pebbly exophytic growth. They show a pebbly surface and they are white in color, from pale pink to white in color. So all the three lesions, they appear somewhat the other in an initial or the final stage, and they look same. So because of their clinical similar spectrum, we have to know about these lesions. Again, the pre-malignant and the malignant counterpart of varicopapillary lesions, they look similar and pose a great diagnostic challenge. Also, they have a similar and correlating histopathological features. The etiology and etiological factors are also similar. That is, deleterious habits like tobacco chewing and smoking. Also, there is a correlating etiological factor, that is human papilloma virus. In this chart, you can see that is these are the oral papilloma, focal epithelial hyperplasia, verrucous carcinoma, verrucous vulgaris, flat wart, cornyloma acuminatum, and conjunctival papilloma. All these are the lesions, and these are and the other side we can see the human papilloma virus subtypes that has been affected, or they cause this lesions. That is subtype number 2, subtype number 6, 11, 4, 40, and 11, etc. Coming to the lesions, I have made a concise chart where all the possible important points have been discussed with their clinical, histological, and diagnostic features of benign, potentially malignant, and the malignant lesions. Coming to the first lesion, that is squamous papilloma. As you can see the clinical picture, there is something exophytic, white color, growth or finger-like projections or cauliflower-like growth can be seen on the lip. And coming to the histology, you can see there is a benign proliferation of the stratified squamous epithelium with the center of the center core connective tissue, and where here the epithelial, because the etiological factor is human papilloma virus, this virus have a potential to alter this normal epithelial cell that is called as coilocytes. In the second image, you can see there's a pictures of these coilocytes. These are nothing but the virus altered epithelial cells. The maximum size of this squamous papilloma is 0.5 centimeter. And how to approach such a lesion, the clinical appearance is very frank, it is easily diagnosed, and obviously the biopsy features will help you to recognize this lesion. Coming to the second lesion, that is focal epithelial hyperplasia, or it is also known as Hex disease. When you see the clinical image, you will see there is an exophytic or hyperplastic amount of growth with a pebbly surface, and this and the histopathology again is similar to the squamous papilloma, where you can see extensive hyperplasia that is happening. Now, apart from the hyperplasia, there is also a hallmark of this lesion, that is acanthosis of the oral epithelium, and also there are all the nucleus, there it will be altered nucleus, resembles like a mitotic figure, and the mitotic figure is nothing but a dividing cell. So that is the reason this different type of a cell, it is also called as mitosoid cell. It is a childhood condition, and the size of this lesion varies from zero point 0.3 to 1 centimeter. And clinically, it resembles verruca vulgaris and oral manifestations of the Crohn's disease. Coming to the next condition, that is condyloma acuminatum. Again, if you see the clinical image, it is an exophytic growth, again a pebbly surface, which resembles the verruca vulgaris and focal epithelial hyperplasia. And when you see something histopathologically, again there is a lot of hyperplasia that is happening in the histology. Apart from the hyperplasia, there is a acanthotic stratified squamous epithelium with mild keratotic papillary surface projections. The teenagers and the young adults, they are very commonly affected with this lesion, and the growth of the lesion is 1 to 1.5 centimeter. And the diagnosis, again, the location and the appearance will give you a frank demonstration of a lesion. But again, there is a coilocytic cellular changes on the slide that will give you a final diagnosis of a condyloma acuminatum. Coming to the next lesion, that is verrucous xanthoma. So when a clinical image, this will give you an idea. It looks very similar to the oral papilloma, where there was exophytic finger-like growth projections also. So this is also a hyperplastic condition of the epithelium, and here the females are most commonly affected with a maximum size of 2 centimeters. And again, as I told you, it resembles the oral papilloma. But when you see the histopathology, there is obviously there is epithelial hyperplasia which is going on. Apart from that, there is an accumulation of the numerous large macrophages with a foamy cytoplasm, and this foamy cells are also known as xanthomas. And this they contain the lipid, and this lipid is positive for the periodic acid shift stain, that is PAS stain. And as we also known as the etiological factor for this lesion to occur, that is human papilloma virus. Coming to the next lesion, that is verrucous leukoplakia. If you see the clinical image, you can see resembles the similar as oral papilloma. But oral papilloma, it was very small, that is only varying about 1 centimeter in size. Here it is well defined, it is big, and it is more than 1 centimeter. But clinically appearance, it looks like a oral papilloma. And when you see something in histology, you can see enormous keratosis that is happening. There is a lot of hyperplasia of the epithelium. So let us know, how do you identify such lesion. So coming to the first one, that is appearance, a white thickened verrucous plaque that may be homogeneous or multifocal in nature. The other point will be growth pattern. It will be slowly progressive. It will start as a flat leukoplakia, later on evolving into the exophytic or a verrucous type of lesion. The as leukoplakia regresses, but the verrucous leukoplakia, it expands over the time. So that is your main important feature when you identify from the leukoplakia to the verrucous leukoplakia. And the malignant potential, the verrucous leukoplakia has a high risk of transforming into the verrucous carcinoma or squamous cell carcinoma. Coming to the histopathology, the epithelial hyperplasia, you can see there is a lot of epithelial hyperplasia, epithelial thickening that is happening, and also elongated and wide rete can be seen. Apart from that, there is parakeratosis and hyperkeratosis that is happening in this verrucae pattern. Again, minimal atypia. So when you see oral leukoplakia, you notice that there is a mild, moderate, or severe type of dysplasia that is happening. But when you diagnose a verrucous leukoplakia, the dysplasia is often absent, or it is in the milder stage. Then blunt papillary projections. So here the papillary projections are not as evident as the oral papilloma. They are little blunt, and they are well demarcated. Coming to the next lesion, that is the most controversial, verrucous hyperplasia and verrucous carcinoma. So verrucous hyperplasia again has two varieties, that is sharp verrucous hyperplasia, as you can see in this image. We can also see that there is this finger-like projections that is happening, that is proliferation of the epithelium onto the upper surface, upper layers. And there is, when you see the basal or basement membrane, it is little broad and they shorten. The blunt variety, there's no pointed proliferations or projections that is happening. It is a blunt projections that is happening. Again, the base or the basement membrane is broad. But when you see the verrucous carcinoma, there is a exophytic as well as endophytic growth. Exophytic means something which is proliferating above the normal epithelium. So there is this exophytic growth that is happening. And again, there is an endophytic growth. That means it is also coming deeper into the connective tissue, and it is pushing, or it is again expanding to the level of the connective tissue. So how to identify or how to differentiate verrucous carcinoma with that of the verrucous hyperplasia, we'll see now. So the first thing, verrucous carcinoma will be exophytic, warty, and cauliflower-like growth pattern it will show. But the verrucous hyperplasia, it will be thickened, white verrucous, or a papillary type of lesion will be seen. In the when in the treatment aspect, when the verrucous carcinoma is it is incompletely excised or some bits have been remain, they rarely transform into the invasive type of carcinoma. But if the verrucous hyperplasia may regress or may progress into the verrucous carcinoma if untreated. Again, the epithelial thickness here will be in the verrucous carcinoma will be thick, will be marked, and when the epithelium of the verrucous hyperplasia will be hyperplastic. We can see evidently in this image also there is this epithelial proliferation taking place on the upward side. So the hyperplastic epithelium will be evident. But when you see in the epithelial thickness, it is again going to the both side, exophytic as well as the endophytic. So the collective thickness of the epithelium is thicked or marked in the verrucous carcinoma. Coming to the retirages, it is showing pushing bulbous or extend deeply, but they do not invade. And here, when you see the retirages of the verrucous hyperplasia, they are thickened, elongated downwards, but they do not deeply penetrate. So here we can see the visible difference. There is a broad shape retirages in this image where you can see verrucous hyperplasia has a broad retirages, but they are not deeply penetrating into the connective tissue. But the verrucous carcinoma, there is an intact basement membrane, but it is pushing, the epithelium is pushing downwards, or endophytic growth is happening here. And also there is the both name carcinoma is given to verrucous carcinoma, but there is no break in the basement membrane. The next is keratinization. There is an extensive parakeratosis or orthokeratosis happening in the verrucous carcinoma, but there is a hyperkeratosis is happening, but it is very less pronounced in the hyperplasia. Also, we can see a deep keratin clefts. So, as we can see, there is here we can see the epithelial hyperkeratosis. Apart from that hyperkeratosis, we can also see there is a keratin plugging which is happening in the verrucous carcinoma, which is absent in the verrucous hyperplasia. So as you saw, the both as we saw, the lesions had similar clinical appearance. So there is a high probability chance that we can sometime mess up the diagnosis. For that, clinical information, adequate biopsy details are very essential for accurate diagnosis. Also, there is a close cooperation needed with the surgeons in the agreement of the potentially malignant and the malignant verrucous lesion. And also there is this message that we have to convey, that also verrucous lesions, you treat them as it is a cancer patient, or as a cancer, as a squamous cell carcinoma, where 5 mm margin should be preserved or removed, and 5 mm margin should be required. And the careful evaluation, proper knowledge of verrucopapillary lesions, regular follow-up wherever there is a need for the lesions will lead to the optimum patient care. Thank you for your patient listening.
Very nice presentation. You're welcome. So, so, Dr. Selvi, you have any questions, or the audience has any questions? Where did everybody go?
Dr. Shivani, that was a very detailed presentation on varicopapillary lesion. So I have a question. What is your take on proliferative verrucous leukoplakia? Will that come
Yes, ma'am.
under?
Yes,
Will that
ma'am. It
come?
is also. Yes, ma'am. Actually, the similar because of the similar because in varicopapillary lesions also it looks very similar, ma'am. That is why I've kept the verrucous leukoplakia also in this section because it seems very evident lesion that is which we know that this might be a leukoplakia, but again the incidence of verrucous leukoplakia is not easily seen. The prevalence is very late, like what do you say we cannot we see normal leukoplakias, homogeneous and non-homogeneous type, very commonly, but the verrucous part it is not that common, ma'am. That's why I've kept how to diagnose those kind of lesion, how to look into them, ma'am. So verrucous leukoplakia, they have a high malignant transformation rate to squamous cell carcinoma, ma'am. So there is if the lesion is like if you're looking into that lesion, proper diagnosis, the well defined margins and everything has to be seen clearly, ma'am. After that, follow up also should be needed, ma'am, for such cases.
So, the presence of coilocytes, does it give anything that you want to convey to your physician, oral physicians, or oral surgeons? Would you like to do something with that information?
Ma'am, because that is, see, ma'am, because we know that the virus has the potential to transform our normal epithelial cells. So that is why the presence of coilocyte will tell us that the virus is altering this normal stratified squamous epithelium. So that is why we can convey we can convey the surgeons that you can go for advanced tests where the HPV virus can be detected. See for the other general symptoms and also the other oral symptoms what the patient is giving.
Okay.
We have one question that is in general to everyone from Dr. Akshay. He says, "Hi everyone, a question to the pathologist here. Do you categorize PVL histopathology into corrugated parahyperkeratotic, not reactive, and bulky hyperkeratotic epithelial proliferation, not reactive, in the histopathology report?" So, any of you want to comment whether you do or do not?
Ma'am, PVL as an entity actually is a clinical term. So when we look at any histopathological report, it can range from hyperkeratosis, oral verrucous hyperplasia, or even verrucous carcinoma for that matter. But in case of when we want to give the term PVL or proliferative varicose leukoplakia, one needs to correlate the findings clinical and histopathological to see if there are more than one homogeneous or heterogeneous lesions which are present in the patient's mouth. These may range from different histopathological reports, but only when we correlate clinically can we call it proliferative varicose leukoplakia. Dividing it further into subcategories will not have any impact on the surgeon's opinion or the clinical decision for the patient. The prognosis will remain the same because there is a high chance of recurrence and it needs to be surgically excised with a clear margin.
True.
So
I think
basically,
it is
all the
also.
lesions whichever are present, which appear like leukoplakia with varicose surface, have to be dealt with and treated in time, so that the
Yes.
propensity of going on to forming squamous cell carcinoma should be avoided.
True. Dr. Akshay himself also says the literature says it's a continuum. So, yeah.
Yes, yes, that is correct.
Okay. Shall we listen to the second lecture and come back?
Yes, you
Yes,
can
ma'am.
proceed.
Okay. So, here's the second lecture, everyone.
Greetings, everyone. I'm Dr. Meghna V. Naik, an oral pathologist from Goa, India, and today I'll be presenting on exophytic varicopapillary lesions in the background of oral submucous fibrosis. I'll be covering the topic under the following subheadings: Introduction, As is known, oral submucous fibrosis is an insidious chronic disease affecting any part of the oral cavity or sometimes the pharynx, associated with juxtaepithelial inflammatory reaction resulting in fibroelastic changes resulting in epithelial atrophy, which leads to rigidity of oral mucosa and progressive difficulty in opening the mouth. The main causative agent is seen as areca nut or the betel quid, along with sometimes smoked form of tobacco and alcohol consumption, resulting in affecting different parts of the mouth with signs involving burning sensation of the mouth, increased or progressive rigidity and difficulty in opening of the mouth, depigmentation, paleness of the mucosa, blistering, affecting the uvula, facial pillars, along with formation of fibrotic palpable bands circumorally as well as on the bilateral buccal mucosa, and later in the disease may also result in formation of white lesions, which is quite prevalent. There is a high rate of malignant transformation which might be understated associated with OSMF. So also it is known as a fibroelastic disorder due to the main pathology lying in the stroma, and more so also known as a Southeast Asian or an Indian disease with limited data available on the extracellular matrix components. Yet it has been presented with exophytic varicose lesions in the background such as PVL, varicose hyperplasia, and varicose carcinoma to name a few. Coming to exophytic varicose lesion, which is a large group of heterogeneous disorders of the oral cavity, the word exophytic was derived from the ancient Greek word exos meaning outside and phyton meaning plant. Thus, the clinical descriptive in pathology, which means arising from the outermost contour or beyond the outer surface of the organ of origin. There are different types of surfaces which might present as exophytic. Here we are focusing mainly on the verrucous and papillary types. Among the various heterogeneous groups of benign, malignant, and potentially malignant, here I'll be focusing on the potentially malignant exophytic lesions, which show a more lateral spread. And in the context of OSMF, it forms a distinct unique entity. Why does the verrucous morphology exist? Due to the continuous exposure from the carcinogen, there is increased thickness of the stratum spinosum, resulting in acanthosis and expanded rete ridges. This results in deprivation of the outermost epithelial cells, resulting in their necrosis and desquamation, forming clefts in between. These clefts get keratinized and form long verrucous or papillary projections with a fibrovascular core, resulting in the verrucous morphology. Due to this, there are various types which can be classified by different authors, such as those which are classified by Shear and Pinbog in 1980, the highly keratinized type, which was described histopathologically as the sharp variant due to long, slender verrucous or papillary processes with fibrovascular cores and high degree of keratinization, mainly orthokeratinization. In the blunt variety, which is also intermixed with homogeneous leukoplakia, it shows more of a blunt or uh, broader projection with fibrovascular cores, but here the keratinization is lesser or more of parakeratin is seen as compared to the sharp variant. In case of Wang et al., they classified it into two types: mass type, which is more associated with malignant transformation and shows thinner or lesser thickness, as compared to the plaque type, which also appears clinically as whitish, as compared to the mass type, which appears whitish pink in origin. These may also be intermixed with homogeneous leukoplakia. Due to this confusion in terminology, at a consensus held at Kuala Lumpur in Malaysia 2013, the term oral varicose hyperplasia was restricted to the appearance of keratin plugging between hyperplasia of varicose and papillary type, which may or may not be associated with dysplasia, and uh, this entity was clinically called as exophytic varicose hyperplasia, which was a single and discrete lesion as opposed to proliferative varicose leukoplakia, which is more of a multifocal disease and a clinical term. Hence, the clinical criteria which were given for exophytic hyperplasia were mainly lesions clinically which showed exophytic fleshy varicopapillary outgrowths or a white plaque-like exophytic lesion which might appear anywhere in the oral cavity. And to distinguish it from squamous papilloma, it is more than 1 centimeter in size, is a discrete and solitary lesion as opposed to PVL, and may coexist with OSMF. The cardinal sign is absence of induration as opposed to oral verrucous carcinoma and oral squamous cell carcinoma. The histological criteria show mainly keratin plugging, a marked hyperplasia with basilar hyperplasia, no invasion into the stroma, that is, no downward growth, presence or absence of mild to moderate dysplasia may be there, lymphocytic infiltrate might be present. To distinguish it from PVL, PVL is mainly multifocal and the histopathology might vary right from hyperkeratosis, oral varicose hyperplasia to even oral varicose carcinoma. It shows a higher malignant transformation rate and is highly refractory despite of treatment and might show high chance of recurrence. Hence, a strict vigilance is required in case of PVL. This is a schematic showing a spectrum of oral submucous fibrosis showing exophytic varicopapillary lesions which can be of various types. The normal oral mucosa shows the rete pegs up to this level, whereas in OSMF there is epithelial atrophy. In hyperkeratosis, there might be increased or hyperplasia, and in varicose hyperplasia, along with the exophytic component, there is a downward rete-ridge hyperplasia which does not extend beyond the normal oral mucosa or adjacent normal oral mucosa. In varicose carcinoma, it is seen that both exophytic and endophytic component is present, that is, downward pushing margin is evident. Hence, oral varicopapillary lesions are very challenging to diagnose since they may range from a variety of different lesions with different types of prognosis, and hence, unless ruled out otherwise, frank malignancy should not be ruled out in oral submucous fibrosis. Yet the question arises, why does the non-dysplastic epithelium proliferate more in an exophytic pattern? Endorsing the same as Jayasinghe et al., the abnormally fibrous connective tissue stroma and oral submucous fibrosis and the different cross linkages might be resistant to the process of invasion, allowing the epithelium to proliferate more in an outward pattern. Thus, the accurate diagnosis can be arrived at by taking normal margins during incisional biopsy with adequate depth and proper orientation of the biopsy specimen with effective communication between the clinician, surgeon, and the pathologist. These are few representative case reports. A 45-year-old male with a chief complaint of burning sensation reported to the department since 2 years. He had all the cardinal signs and symptoms of oral submucous fibrosis with 30 millimeters of mouth opening, showing a plaque-like white lesion on the right buccal mucosa. This was biopsied with a provisional clinical diagnosis of leukoplakia with oral submucous fibrosis. A histopathological diagnosis of oral varicose hyperplasia was given, looking at the rete ridges and all the criteria, histological criteria. Yet, the final diagnosis was changed from exophytic varicose hyperplasia to proliferative varicose leukoplakia since more similar lesions were seen even on the left buccal mucosa, palate, as well as labial mucosa. Another case of 60-year-old female patient, a habituee of areca nut, co- came with the chief complaint of pain in the lower lip since 5 months. Since the duration was short, a provisional diagnosis of oral squamous cell carcinoma with concomitant oral submucous fibrosis was given. On histopathological examination, fibrovascular course with varicopapillary exophytic pattern was seen, and on deeper biopsy, it showed invasion with pushing margins, elephant-shaped retipegs, thus coming to a conclusion of varicose carcinoma with oral submucous fibrosis. Hence, it can be concluded that exophytic lesions arising in cases of oral submucous fibrosis should raise a direct clinical suspicion of squamous cell carcinoma unless ruled out otherwise, and an effective communication between the clinician, surgeon, and pathologist is required for appropriate diagnosis. These both being distinct entities together coexisting, make the patient twice prone to malignant transformation, and thus vigilant and strict supervision is required with strict regular follow ups. As future perspectives, assessing samples from these predisposed regions of Southeast Asian countries are required, and a need for longitudinal study with larger sample sizes is required. These were my references. Thank you.
Yes. Very nice presentation. Okay, we are having a feedback from somewhere. Okay. No, no. Any of you logged in from two places? Okay, let's see. Okay. Nandini is only able to hear us, so she will be making her judgment, but she cannot comment. So, Selvi, it's you would like to say something?
Yeah, yes, Dr. Megha, that was a very
Yes.
interesting presentation,
Thank
varicopapillary
you, ma'am.
lesions in oral submucous fibrosis. So, my question here is, how frequently do you see varicose lesion are in association with oral submucous fibrosis, or do you see malignant transformation more frequent? Malignant
Very
transformation into squamous cell carcinoma.
Uh, Ma'am, more prevalence is of squamous cell carcinoma transformed. That is due to the high prevalence of leukoplakia in oral submucous fibrosis. Varicose lesions are rarely seen, from around zero point 0.3 to 6%, but not more than that. But whenever they present, they may potentiate the malignant rate of transformation right from say 6% to around 42%, which is shown in literature.
Okay, and one more question I wanted to ask you is you talked about proliferative verrucous leukoplakia in association with oral submucous fibrosis. So, is it being reported like that in literature? Have you come across cases like that?
Yes, ma'am. I've come across two cases of such type where oral proliferative varicose leukoplakia was one of the diagnosis, where histopathology was showing varicose hyperplasia, and the patient had more than one lesion involving one on buccal mucosa, labial mucosa, as well as in the alveolar mucosa. Even in my practice from around 1.5 years, I have seen at least two of such cases, which we have
So,
not yet documented, but
okay.
we have seen these cases, and so far, varicose lesions, around four cases with oral submucous fibrosis have been reported, and all of them have been from the Southeast Asian region.
Okay, that is very interesting, and maybe you should make an attempt to document it. Yes. Thank you, Dr. Megha.
Thank you, ma'am.
By the way, everyone in the audience, we are running the poll on YouTube itself. You can vote right there within YouTube. But I will not be leaving it on there endlessly. So finish voting because quite soon I will remove it. Yes. So nice presentations, I must say.
Yes.
Thank you, ma'am.
Have
Thank you,
any of
ma'am.
you thought what you're going to present if you become the rising star? What topic you will choose? Not.
Honestly, no, ma'am. I have three topics in my mind, but I'm not sure which one I will present. Yeah, just a vague three topics I have.
What about you, Dr. Meghna?
Uh, Ma'am, I like oncopathology. So
You are
my
leaning to
yeah, my
oncopathology.
leaning towards oncopathology or dermatopathology, one of the two. So
Yes. Interesting. Interesting. Right. Let us also move to the giveaway screen so that people can start.
Oh,
So, everyone, you can start typing. What you need to type is this, which is on the screen. Basically, it's the name of the conference, or rather, the short name of the conference. It is IODCPC 25, that is International Oral Diseases Case Presentation Conference. When we started naming the conference, we didn't think that in the long run it would be rather long, but this is the name we have. And much as we have thought, but it is the most representative. It's not possible to remove any part of it.
Yes, ma'am.
So to be a part of the giveaway, to qualify, you got to type IODCPC 25 with a hash, of course, and that's it. Just type it in uh, in the chat. Hi, Krishna. Yes, I know. She is an old hand at this. So she was the first one also to type and a regular at the channel. Yes. So, everyone else also please add your comment so we can see. And in a minute or so, we will go for the giveaway. We will have the draw. Yes. So, Dr. Meghna, what do you think of our lineup of speakers for the conference?
Ma'am, all of them are excellent visionaries, and they have done a lot of work in oral pathology and this field, and they have taken to the global stage prior to this also. So looking forward to listening to them.
Although I have to mention, there are a lot of speakers from other fields too.
yeah.
Yes,
This time, yes, we have oral medicine, oral surgery, oral radiology, and we also have topics that are relating to general dentistry. But I think you will find specifically the topic which is on choosing risk. Oh, it's actually on the screen. Risk assessment in elderly dental patients. What
Yeah.
timing? Okay. I was trying to remember, rack my brain as to what was the title. So yeah, that I
topic
think,
on
given
geriatrics.
your other interest, you will find that interesting.
Yes, ma'am. Yes, ma'am.
What about you, Dr. Shivani? What do you find interesting? Have you gone through the speakers?
Yes, ma'am. Yes, ma'am. And it was the first conference where I attended in 2020, ma'am. So that was also our first conference. Our HOD sir made us attend that conference. And yes, obviously the panels are excellent members who have contributed so much. It is like us, we learn so much from them, obviously.
Yes, true. Well, we do really work very hard to choose the speakers. I mean, like
And the
someone
topics
mentioned.
are also interesting,
Yes,
ma'am.
true.
Yes,
But then that's the choice of the speakers. We have nothing to say about them. We can't take it credit for the topics they choose. We can only take credit for choosing them.
yes,
Now that Dr. Meghna mentioned that she is leaning towards dermatopathology,
Hmm.
I would like to mention that one of the keynote speaker, Dr. Kiera Bar, she is going to talk about oral triggers for in relation to dermatology.
Yes.
So
yes.
yes. Mm.
Her work is very interesting, actually. The way she of course, it's not just oral that she works. She works basically overall with skin and how stress affects skin,
Hmm.
from the mild things like aging
Okay.
to the more serious one where there's a pathology that happens just because of stress. Very interesting talk. She has interests in what is that thing? PNI, psycho neuroimmunology. Yeah, I think I
Okay.
got it right. Okay, I am ending the poll there, everybody. And, yes, the poll is ending. Let me just write it down, just in case YouTube decides to make it disappear. Yes. And therein ends the poll. Okay. Right. I think that's enough time for everybody who wanted to type to have typed. And yes, I can tell you all the result of the vote. So 13 people voted. Dr. Meghna got 53% of the votes, and Dr. Shivani got 46% of the votes. So that is as far as the voting went. The judge's decision will be different, and we take a weighted average of both the things together. Okay, we're gonna run this now. Everybody hold your breath. Krishna, you got it. Wow, that's okay. Congratulations. Cool. That was fun. Okay. So anyway, she got it. Yes. So, and for those who didn't, do not despair. We have in our next live stream, we will still be having giveaways. But of course, now that is after 2 weeks. As everyone I'm sure is aware, we are live streaming twice a month, not every week. Cool. So, yes. Right. Nandini, are you with us? Can you say anything?
Yes, ma'am.
Oh, you're
Yes,
there.
ma'am. I'm very
Oh,
much there.
okay, wonderful. Okay,
Yeah,
yes. What can you say? What would you like
that
to
was a
say?
wonderful presentation from both. Both presenters were equally good, ma'am. They have brought
Thank you, ma'am.
in new insights. You know, it was an overall comprehensive review as such, and some case presentations were also presented by Dr. Shivani. So both congratulations, Dr. Meghna and Dr. Shivani. Both of you did very well.
Thank you.
Thank you, ma'am.
Yes,
Yes,
thank
And of
you.
indeed.
course, the lesions, especially the varicose hyperplasia in OSMF and all, it needs more of research, multicentric research, as they are quite rare. And of course, if there is dysplasia in such things, the grading of dysplasia is again controversial, because the depth of, the whether it is in the lower third of the epithelium, or till the middle third, or entire third, like, mild, moderate, severe,
Absolutely.
that grading
Yes,
of leukoplakia in, especially in
quite.
those with OSMF, is becomes a cumbersome thing,
Yes,
because of the fibrosis. So that has to be, some guidelines on how to we have to formulate that, and it should be
yes,
uniform throughout. All the researchers across the world give uniform grading for that. So that area is a gray area to be explored still. That is
true.
my
Yes.
opinion. So congratulations again for both the presenters.
Thank you, ma'am.
Yes, totally agree. Both were really good. Nice content, nice presentation too, and nice topics too. So, on all fronts, they were good.
Thank you, ma'am.
Yes. Okay, we are
So
not getting any more questions from the audience. Any of you want to ask any more questions?
I think both presentations were good, and yes, very well presented, and with cases also. Yeah, like Nandini said, yeah, some things need to be still researched, but
True.
all the best. Let's
Thank you,
see
ma'am.
Thank you.
who becomes the star,
Yes.
rising star. But both of
Thank,
you have done very well. Yes.
Thank you so much, ma'am.
thank you,
Thank
ma'am.
you.
Both of you have indeed done very well. Very proud of both of you and wonderful. And all
Thank
the
you.
Thank you,
best.
ma'am.
Thank you, ma'am.
Thank you, ma'am.
Welcome. And thanks to our audience
Both
as
are
they enjoy
winners
being with us.
because they
Sorry,
have
Nandini?
presented in such a very
Mm,
yeah platform. Yeah.
yes.
Thank you, ma'am.
Thank you, ma'am.
Okay. So, dear audience, we will catch up with you in 2 weeks from now with Dr. Sharda's lecture. And thank you all for being here with us. And thank you so much, Dr. Selvi and Dr. Nandini,
It
for
was my
judging.
pleasure. My
Thank
pleasure.
you. Thank you. It's always a pleasure to have you all with me and spend time under any pretext is always fun. So, thank you so much. Bye
Thank you,
bye,
ma'am.
folks.
Our pleasure
Bye, ma'am.
Bye, ma'am.
to be
Thank
always
you.
back.
Thank you, Nandini. Thank you so much. And thank you, Shivani
Thank you,
and Meghna.
ma'am.
Bye.
Thank you, Mandana, ma'am. Thank you,
Bye.
Bye,
respected
Bye,
judges.
folks.
everyone.
Bye.
Welcome.
Bye, Dr.
Bye, ma'am.
Shivani.
See you all.
Yes,
Have
ma'am.
a
Bye.
wonderful time. Be safe.
Bye, Meghna.
Thank you,
All the
ma'am.
best.